Hello, Dr. Russ here. Today on the table we have Denise, and Denise is kind enough to let us share, and the most important aspect of it is that she has Marfan syndrome. So, genetic condition creating loss of strength and loss of elasticity in the collagen. So, all of the connective tissues are affected: ligament, tendon, joint, bone. All the connective tissue around the muscle is affected, and the gene is very strong in Denise's family, which just told me today that she's third generation from her mother's side as far as she knows, and that on her mother's side, out of 6 siblings, 5 had Marfan syndrome. Is that right? One of the ways that this shows up for Denise is that she has a scoliosis. So you can see the asymmetry in her ribs here is where it's the most marked. And the pain that she gets is pretty predictably along the rib hump on the right side, around the shoulder blade, down the ribs, and it comes up and it affects her cervical spine too. So we want to help her out with that, knowing that we're not going to be able to reverse the scoliosis, and we're not going to be able to reverse the underlying genetic condition. So that keeps our goals, you okay? That keeps our goals to be about pain relief, which is usually about circulation and mobility. But with the Marfan syndrome being present, we have to be extremely cautious about how much pressure we use and how much movement we try to induce. So I thought this would be an interesting session to document and share because of all those contraindications that are in place. So when we started working together quite a few years ago, we talked a lot about what we could and couldn't do, what kind of treatments I would and would not try, and always definitely her safety being the most important thing. And no matter what we do not want to create injury or harm. So we always approach Denise very gently, incrementally, and I would say if, the technical contraindications, number 1, no deep pressure. Number 2, no mobilizations greater than grade 2. And grade 2 is an easy passive range of motion without reaching end range. I certainly have not done any thrust adjustment on Denise ever, and I never would. Number 1, it would be dangerous to put a thrust through any of these joints. And number 2, there would be no point because the ligaments and the joint capsule doesn't have the elasticity to hold the adjustment. So as we're working right now, starting at the skin and superficial fascial level, I'm always interested in Denise in her dorsal scapular nerve, which runs right here, and she's nodding her head. And I'm palpating it here. You can kind of see it right there. Flicks a little bit under my finger. So that gets stuck, usually on a rib transverse process joint, a costotransverse joint, which will become swollen and irritated because of the scoliosis. And then as it swells, it enlarges, and either that enlargement or just the bogginess of the local edema will entrap or irritate the dorsal scapular nerve. And that creates a lot of pain in the ribs and the posterior scapular area. So we're always interested with Denise in trying to release any of that we find. And the next thing we want to do is mobilization of these ribs. So a couple of nice deep breaths. Good. So it moves pretty well as a whole. The rib cage does. The deep inspiration really brings out in her this posteriority right here, this prominence. This rib, I would call this the 6th rib. Doesn't matter if it's exact or not. But the point is, the way that her scoliosis has come here, convex on the right, has caused a little bit of opening of the rib cage, and that has created space for this 6th rib to grow a little bit posteriorly. And again, we're not going to correct that. We're not going to adjust that back in, so to speak. But what we want to do is make sure that it has as much healthy movement as possible. and make sure that we're attending to the intercostal muscles and making sure they're not staying congested and irritated, because that can create a lot of pain and restriction with breathing. Good. 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 How's the pressure, Denise? Not
Good.
too much?
No.
Good. Good. So you can see I'm, with my pressure, definitely deforming the skin, and I've got the superficial fascia between my fingers. You can see that my nails are a little bit white, so there's definitely some pressure, but it's not enough to move or deform the bone. It's just right up to the level of the bone, and that's it. That's as far as we're going to go. And we're still just kind of getting her warmed up, getting things moving. Let's look down here at the lower back. Okay, same idea. Working through the layers. And we know there is a left convex scoliosis in the lumbar spine. So when there's a sense of malposition or poor alignment, we don't really want to spend too much time thinking about that. Really much feeling more for relative mobility between the vertebrae and between the layers of soft tissue. That's actually moving pretty well today. Sometimes her lower back can get pretty stuck. So let's come on up to the neck and see what we can feel there. Orienting ourselves now to her cervical spine, superior angle of her scapula right there. C7 spinous process right there. So those rhomboids right here, and it's tight, it's really tight. So we're going to come back to that in a few minutes as we induce better position of her scapula and try to restore that superior and medial glide of her scapula, which is what these rhomboids are trying so hard to accomplish. And come up here through the neck. Gentle now. Good. Feeling like the tension and restriction through here is pretty minimal. And coming up here, there's her mastoid right there. And right up under the occiput is where there's a little bit more. I think that's pretty typical for her. Denise, is this pressure okay? Mm-hmm. Good. So again, just gently working the insertion along the occipital line of all those neck extensors and suboccipital muscles, just to the level of the bone. And you can see the movement starting to increase there as we work that line. So let's do that again. Nice. Nice deep breath. Good. We're going to work up a little higher. Good. And while we're here, let's work with the temporalis muscle. Okay, so she seems pretty relaxed, and we got her tissues nice and warmed up. So now let's look more at the relationship between the scapula and the rib cage, okay? So if I took your top arm, and you just kind of let me have it. Nice. Is your bottom shoulder pretty comfortable? Mm-hmm. Yep, okay. So here's her scapula. Just relax the arm for me, Denise. There's no helping. Good. So as I push on it, you can see it right there. There's the inferior angle here. There's the lateral border there. Okay, now in a lot of my videos, you really see me going after the lat and the serratus. We're not going to do that here today. I don't want to dig under her shoulder blade. It's not really safe for her. Don't think that her connective tissue would really respond well to that. Okay, so instead what we're doing is using induction to create the mobility of the scapula coming back along the rib cage. In doing so, we're getting a stretch through her serratus anterior, trying to keep her rotator cuff and her subscapularis pretty much neutral. So the force that's going through her shoulder is going straight this way. We're not stressing any ligaments or tendons of her rotator cuff. We're keeping this really easy on her shoulder, on her scapula. And so here I'm looking for separation, right? A little bit of posterior movement of the scapula in relation to the rib cage, and right there is where it really gets hung up. That's our area of concern. So here I'm kind of gently holding that rib. I would say that's probably rib 5, if not the same rib 6 as before, giving it a little bit of support as I gently move back posterior with that shoulder blade. A nice deep breath and let it out. I want you to just kind of let me move you through this range of motion a few times. Good. One more time. The scapula ends here. It doesn't overlie these lower four ribs or so. It's still intensely related anatomically, biomechanically, and we want to make sure the movement, that relative movement there, is intact. Good. Coming back up, back through our problem area. You can see the whole position of her rib cage has shifted. She's leaned back a little bit more. That's all fine. It means she's relaxed and just letting her weight sort of start to roll. The less she's holding herself, the happier I am. We okay here? Deep breath. There's the spot. Breathe on out. Again, I'm just getting a little lower, but I'm not using any more force. It's pretty direct, but it's very gentle. Okay. That was a lot of movement we just put through there and a lot of sustained pressure, so we're going to give her body a little break. How are you feeling?
Okay.
Feel okay? Not too much?
No.
Would you tell me if it was?
Yes.
Yeah, good. Okay, so while we're giving that a break, let's come back and check in with the upper neck again. Yeah, I think this is worth another go today. Right here, behind the mastoid, that inferior occipital line right here. You can see her upper trapezius right there. Really nicely defined. Good. Good. Okay, let's feel that scapula one more time. Okay, good. So this is relaxed. Good job. Just give me the weight of it. I got it. There you go. Good. Thank you. It's moving really much better. Still a little bit of a catch right there. Deep breath. Breathe out. Good. Okay. So this move here is a little different than before. I was able to get the scapula back into a good retracted position. That brought up some tension here where the triceps meets the lat. And again, I'm not going to dig. So what we're just going to do is give it a bit of a fascial stretch here. So just with the friction of my palm and fingers, coming back and down here and giving a tiny little bit of traction on the humerus, just until I feel the very, very initial sense of soft tissue engagement. Okay, with connective tissue disorder, we don't want to stretch people because they're not elastic. We want to mobilize them, make sure their circulation is as good as possible, and that will help take stress off of the structure and reduce the pain in their body. How you doing? Good.